Bismillahirrahmanirrahim. Assalamu alaikum and a very good morning to everyone. I am Dr. Nabila Khalid, moderator of today's session. Welcome to all. Today we have an excellent pile-up of speakers who will be covering almost all the topics related to the orbit and the thyroid eye disease. So we are already short of time. Don't waste our time and let's start. Our first speaker is Professor Dr. Asad Aslam Khan, who is the name of dignity, devotion and dedication. He is presenting imaging in orbital diseases. Sir, please.
Bismillahirrahmanirrahim. My talk is about imaging in orbital diseases, because many times our postgraduate residents and our junior ophthalmologists who aspire to become orbital surgeon, they must know the radiology that every surgeon know at least. My talk is dedicated to my mentor, Professor Muhammad Munir Haq, who taught me the orbit, and Professor Tayyib Sahab and so many others. Surgical and brief about surgical and radiological anatomy of the orbit. We all know it's a pear shape. Walls, apex and base are curvilinear. Apex and base are composed of thick bones. Walls are thinner and perforated by various foramina. Length is 45 mm from medial orbital rim to apex. Medial walls are parallel to sagittal plane, and lateral walls are short by 10 mm recess at 45 degrees. These are the surgical spaces of the orbit. We have intraconal space. We have the intraconal space that is within the muscle cone. Then extraconal space that is outside the muscles and inside the periosteum. Then there is subperiosteal space that is between the periosteum and orbital wall. And fourth one is the extra orbital spaces, cranial spaces, nasopharynx and paranasal sinuses. So intraconal, extraconal, subtenon space, subperiosteal space and extraorbital spaces which include paranasal sinuses, intracranial cavity. So this is just about the spaces. The extraconal space, this is between the muscles and the periosteum. Intraconal, within the muscle cone. The lesion distribution is such that most of the intraconal lesion, extraconal lesion, they are mainly the cyst, lesion of the lacrimal gland or cavernous hemangiomas or peripheral nerve tumors, mainly schwannomas. Subperiosteal abscess is commonly seen in cases between the space, subperiosteal space, and in the intraconal space, the lesion may be below the optic nerve, above the optic nerve, medial to the optic nerve, or lateral to the optic nerve. And the most common lesion which are seen in intraconally located, they are obviously the optic nerve tumors, neurofibroma, schwannomas, lymphangioma, hiatus cyst, cavernous hemangioma. So these are the common intraconal lesions which we come across. And dermoid and cavernous hemangioma. Contents of the orbit is very easy to remember. Figure of 7 muscles, 7 bones, 7 nerves. So they are the part of the orbit. We don't have to discuss in detail. This is the arrangement of the extraocular muscles, facial planes, nerves, and then orbit communicates, and that communication is either through the optic canal, superior orbital fissure or inferior orbital fissure. Now how to image orbit? There are different modalities. The radiological option, number one is the sound waves, and that means B scan. Then the X-rays. It may be simple X-ray of the orbit or it may be CT scan. Then there are radio waves and magnetic field, which is MRI. So these are the three radiological option: ultrasound, radiation, and magnetic waves. Now, how B-scan works? B-scan is based on the reflection of sound waves from an interface between two media of varying density. Reflection of sound from the interface between the two media of two varying density. There is electronic pulsar source, then it goes piezoelectric crystal in the transducers stimulated, then there are resultant sound waves, they enter into the orbital or ocular tissue, and then they are reflected back to the transducer, and from transducer they are picked up by the receiver system, and the receiver system eco-amplified according to the strength by the receiver. At the same time, this is what we are watching on the screen when we are performing the B-scan. Incident sound wave is reflected depending on the density difference between the two tissue interface, tissue 1 and tissue 2. And then there is a propagated wind. Some waves are reflected and some waves they pass through the tissues. More is the heterogeneity of the tissue, more is the reflected wave, and higher is the ecogenicity. And this is true for orbital tissue. They are more heterogenic. How orbit is scanned? Either transocular or parallel to the eyeball. Green arrows, they show transocular orbital B-scan that is used for mid and posterior orbital lesion. These are good. Mid and posterior orbital lesion. Whereas paraocular rays, blue arrows, they are a paraocular orbital B-scan are useful for anteriorly located lesion of the orbit. Oh, this is the orbital tissue. This is the vitreous cavity. Orbital tissue has high reflectivity on A scan as seen by high continuous peaks after sclera. You can see this is sclera and this is the orbital tissue. And on A scan there are high waves after. This is the orbital tissue. Orbit is very eco-dense on B scan. This is due to heterogeneous tissue architecture of the orbit. Lesion scanning using B-scan probe. The transocular scan in this probe orientation will see the maximum thickness of the lesion. Transocular will tell you the maximum thickness of the lesion. Whereas the paraocular scan in this probe orientation will see the depth of the lesion on the orbit. This is a paraorbital. It tells you the depth of the orbital lesion. So this is the thickness of the lesion, transocular, and this is the paraocular, this is the depth of the lesion. What are the advantages of B-scan? Non-invasive, quick and convenient, portable, no sedation, and it is very good for children. Suited to image orbital soft tissue, complemented by Doppler, kinetic properties can be assessed. Small probe, unusual configuration mass can be scanned with the help of small probes. In vivo scanning of histological architecture, heterogeneity of orbital tissue lead to eco-dense scan ideal for disease detection. And this is ideal for follow-up because we cannot repeat every time the CT scan or MRI. Disadvantages of B-scan: lesion near apex cannot be scanned. Periorbital structures not visualized. Bones are not visualized. Used as a part of investigation, not at singular difficult to interpret than CT and MRI, and user-dependent interpretation. These are the disadvantages of B scan. Now, how the lesion seen on A scan and B scan? Lesion is seen as low signal between high peaks of sclera and bone signal. Lesion is seen as low signal between high peak of sclera and bone signal. This is the bone signal, and this is the lesion. And lesion is seen as splitting of the equals dense structure by the hypodense lesion. You see the hypodense splitting of the lesion. Now coming to CT scan, the second modality to image orbit. In CT scan, the X-ray they pass through tissues to fall on the detectors. X-ray tube they rotate around the patient to give you 3D view. Depending upon density of the tissue, X-ray are attenuated and targets stay white. That is why the lesion appear as because the rays are attenuated. Less dense tissue like air allows more rays to pass and film turns more black. So that is why vitreous cavity on CT scan it appears black. Nomenclature of CT scan. Compare the orbital tissue with the brain. Tissue density same as the brain, this is isodense. Tissue density more than the brain, it is hyperdense. Tissue density less than the brain, it is hypodense. So comparison is compare with the brain tissue. Advantages: excellent bone scan because we can't have detail with the help of B scan or even with the MRI. So with CT scan we can have the details of the bone. We can detect calcification. We can do this procedure on emergency basis. Ideal for orbital foreign bodies. Very good for acute hemorrhage. Provide precise anatomical relationship. Can be done with contrast. And better than MRI for metallic foreign bodies because MRI is contraindicated in cases of metallic foreign body. Complement ENT parallel sinus evaluation in orbital cellulitis or mucocele extension. What are the disadvantages of CT scan? Ionizing radiation. We all know it can itself lead to cancer. Limited soft tissue contrast compared to MRI. Poor evaluation of optic nerve, orbital apex, extraocular muscle infiltration. And with the use of contrast, ionized contrast, there is risk of nephrotoxicity. So we can't use in patient with renal failure or renal disease. Metal streak air artifacts, functional tissue characteristics, inferior for inflammatory, demyelinating or infiltrating optic neuropathy. May miss very small soft tissue lesion unless they change density or contour and not suitable for pregnancy unless essential. Now coming to the third modality to image orbit, that is the MRI. There are unaligned hydrogen atom in a tissue, but MRI does static magnetic field applied to align in the one direction, and then second dynamic magnetic field leads to atom alignment as per the second field, and second field switch off and atom realign as per static field, releasing the detectable pulse. Again, the terminology will be compared with the brain. That was a hypotense. This is hypointense, hyperintense, and hypointense. And isointense mass is, this is the isointense mass in the vitreous cavity. Hyperintense with contrast and this is hypointense T2 weight images. What are the advantages of MRI? Soft tissue contrast, multiplanar imaging, no radiation. We can easily scan optic nerve and we can differentiate between optic nerve and the lesion which are surrounding the optic nerve. So like B scan, it helps in differentiating between the optic nerve and the lesion surrounding the optic nerve. CT scan doesn't differentiate between optic nerve and the lesion which are adjacent to the optic nerve. Advantages of MRI, there we can scan the orbital apex, especially the cavernous sinus. Inflammation versus fibrosis, early marrow filtration, especially important for lymphoma, leukemias and metastasis. CNS and sinus extension, especially in mucormycosis. Contrast, tumor versus abscess, vascular lesion, fat suppression and surgical planning. It is very helpful in surgical planning. Disadvantages of MRI, in the presence of metallic foreign body, we cannot advise MRI. Poor bone detail, almost no bone detail in MRI. Motion sensitivity, blinking, eye movement, degrade MRI more than CT scan. Slow scan time, acute hemorrhage detection. CT is better for acute hemorrhage detection. Sinus cellulitis evaluation, it is difficult with MRI. Claustrophobia, that is very important factor, claustrophobia. And now last two slides, when we are describing CT scan or MRI, first describe the image, plane, it is coronal, it is axial, it is sagittal. Then the terminology, use hypo, iso, hyperdense, hypo-iso, hyperintense. Then define the mass. Then tissue of origin. Position, whether it is intracondylar or extracondylar. Biological behavior. It is pusher or eater. The relationship to adjacent bone. Shape of the mass, round, oval, irregular, kink, optic nerve, like. Internal characteristic of the mass, homogeneous, heterogeneous, solid, cystic. Then comment about the capsule and finally contrast enhancement. This is a section in a CT and MRI. This tells you the different planes. This is the axial plane, this is the sagittal plane, and this is the coronal plane. Axial and coronal section of the patient showing extracorneal hyperdense section in a CT scan. This is the mass, this is the axial, and this is the.
Excuse me, sir. We are having short of time.
Thank you very much.
Thank you very much for your excellent presentation. I am Dr. Said the Associate Professor. This was an excellent presentation, not only for the residents but also for the practicing pathology. My simple question is the practical question we have. When you put the probe, it takes from orbital lesion, already the inflammatory mass or the cyst or the tumor has filled the organ. Where we put the probe, the white mark on the probe, where do we have to put that white mark? White mark? There is a white mark on the probe. Yes. Where would have for a position of that probe? It is where you are suspecting it is either transocular or parallel to that. Transocular or parallel to that. If you are suspecting the mass in the middle of the orbit or near of the orbit, then we go transocular. We have to know the depth of the mass and we go parallel to the.
So there is a mark always on the probe, and that we have to must orientate according to the lesion that is being present, either transocular or translinear. So that is a very important message to be known. Those who are doing yourself either or by the residents, you must know where is your white mark on the probe is.
Yeah,
that is very.
That's very important. It's for orientation. If it's down, you should know
Yes.
So you should write it down there. Where is the white mark? It's for orientation. So we'll go ahead, please.
Thank you.
Thank you so much, sir, for an excellent and well elaborated presentation on diagnostics. So now our next speaker is the special guest all the way from Turkey, Dr. Ken Azurkar. He will be presenting on staging the surgical care in thyroid eye diseases from decompression to eyelid refinement. Welcome, sir.
Once again, thanks to the Ophthalmological Society of Pakistan for organizing this wonderful meeting. And my name is Can. I think it has the same meaning in your language. That was what I was told by Dr. Khan. So my talk today will be about surgery in thyroid eye disease. When I try to explain the patients the course of the disease, when I try to tell them the Rundle's curve, I always give them the example of fire in the house, because thyroid eye disease is like a fire in the orbit. So in the active phase, we have fire, and we use all the medical options that we have to stop the fire. And once the fire is over, once we are in the inactive phase, we evaluate the burden that's left from the disease itself and make our plans for reconstruction. So, to start with the surgery, ideally, the patient has to be inactive for at least 6 months. But by inactive, I mean his hormone levels have to be normal, and also he must have normal antibody levels, and his antithyroid medications has to be discontinued. Of course, there are exceptions. There are some emergent cases where we need to do the surgery in the active phase, which are dysthyroid optic neuropathy, corneal exposure, or glove subluxation. Traditionally, we do a stage surgery because each step affects the other one. The first step is orbital decompression, which will change the position of the eyeball and the muscles, and therefore may cause strabismus. And then as a second stage, if necessary, we do the strabismus surgery, which can affect the position of the eyelids, and the final refinement comes with the eyelid surgery. So for the orbital decompression, mostly we can address 3 walls: medial, inferior, and lateral walls. For medial wall decompression, we usually prefer a retrocaruncular approach and go behind the medial canthal ligament directly to the medial orbital wall, and we can have access from posterior lacrimal crest up to the orbital apex. Here, an important landmark are the ethmoidal foramens, where the vessels are passing, and we have to be careful to avoid any bleeding. And also, this is the same level for the cribriform plate. So if we go higher than that, we may get CSF leakage. For the lateral wall, for us, for oculoplastic surgeons, eye surgeons, the easiest way is to use the lid crease incision. We can have direct access to the supertemporal orbital rim, and then we make a keyhole on the orbital rim to have a better access and view of the deep lateral wall structures, and then we can go down and thin out the lateral wall and have some extra space on the lateral side. So orbital decompression changes the position of the eyeball, as I said before. So when we do the lateral decompression, the eye goes back and laterally. And when we do the medial decompression, the eye goes medially. If we combine them together, which is called a balanced decompression, we have a better axial correction of proptosis. If we need to address the inferior wall, we can use the transconjunctival approach, which gives an excellent view of the orbital floor. And here we have to be careful about the infraorbital nerve. We can remove the bone on the lateral and medial side of the infraorbital nerve, but we have to protect the nerve to avoid any complication. And also another structure which is important to be protected is the orbital strut, which lies inframedially, which is the border between the ethmoid sinus and inferior maxillary sinus. And protecting this strut minimizes the risk of diplopia and hypoglobus after the surgery. There's a very large meta-analysis from Gioacchini from 2021, which says the most preferred method for decompression is, in general, balanced decompression, 1/3 of the cases, and the second one being 3-wall decompression. The average correction of proptosis is 4.5 millimeters, but this depends on the patient and can differ, can be higher and lower than that. And it's higher in balanced decompression, close to 5 millimeters, and over 5 millimeters with 3-wall decompression. Diplopia can happen in 12% of the patients. The risk is highest in medial wall decompression and lowest in lateral wall decompression. The decision for which walls to remove is based mostly on the severity of the proptosis. If proptosis less than 24 millimeters, we can do a single wall decompression together with fat decompression, and usually we prefer the deep lateral wall to avoid diplopia. If it's more than that, between 24 and 26, we can use balanced decompression. If it's higher than that, we probably will need a 3-wall decompression, and we can always combine bony decompression with fat decompression. In dysthyroid optic neuropathy cases, we usually prefer 2-wall or 3-wall decompression. There's a good study from 2015 by Korkmaz and Konuk from Turkey, and they looked at the visual results of two different techniques, 2-wall and 3-wall decompression, and they found that there was no difference in best corrected visual acuity and color vision between two techniques. But in terms of improvement in visual field and proptosis, the 3-wall decompression was much more successful. This was a patient who came to us with a very low vision because of compressive optic neuropathy, and the optic nerve was stretched as well at the same time. And we did a 3-wall decompression on her, and after that, her vision improved, full on the left side, 0.9 on the right side, and as a result, she had strabismus on the right eye, which was corrected later on with a second surgery. For strabismus surgery, I don't do that myself. I let my strabismologist colleagues do that. But we have to have some information that we can give to the patient. First of all, the aim of the surgery is mostly correction in primary and reading positions. Unfortunately, it's not always possible to correct the diplopia in all directions of gaze. And also, if the proptosis is higher than 25 millimeters, it's better to do a decompression first, because after strabismus surgery, the proptosis may increase. And the timing for strabismus surgery is 3 to 6 months after the orbital decompression. Nomograms that are used for strabismus are not safe because restrictive strabismus is totally different, and many surgeons prefer adjustable sutures for that. And recessions should be preferred, and resections should be avoided as much as possible. When we come to the eyelid surgery, there are many possibilities. I will not go through all of them. I will just tell what I'm using mostly. For eyelid retraction, less than 4 millimeters or up to 4 millimeters, I usually prefer a small incision blepharotomy. As Dr. Khan explained yesterday, you make an incision on the lid crease, a small incision, and then go through it full thickness, and you can extend it medially and laterally to tighten the height of the eyelid. This was a similar case and didn't have any proptosis and was okay, didn't need a blepharoplasty, and was fine with the end result, was happy with the end result. For cases with more eyelid retraction, or for cases where I will do a blepharoplasty, I prefer a full thickness blepharotomy, where you make a full thickness incision but leave a small bridge of conjunctiva still intact to avoid flattening of the lid contour. This was a similar case, a young lady. She wasn't bothered by the minimal proptosis she had, and we did, I did upper lid blepharoplasty and full thickness blepharotomy at the same time. And for the lower eyelids, lower lid retractor recession, and used for the lateral side to help with the scleral show, some small 2 ear cartilage grafts, spacer grafts. There's also a new discussion between state surgery and simultaneous surgery. There are some studies, when we do all the surgeries step by step, it takes usually around 18 months or 2 years until the patient sees the end results, and all of the patients may not want to wait for that long. So this patient was operated for orbital decompression, two-wall decompression. He developed diplopia and strabismus. Strabismus was corrected 6 months after, and 6 months after that, we did the eyelid surgery, but it was 1.5 years. Some studies say that we can combine, in selected cases, eyelid surgery and strabismus surgery together at the same time with the orbital decompression. I don't do strabismus myself, and I think as the surgery for a three-wall decompression takes too much time and causes too much congestion, I don't prefer to do all of them at the same time. Sometimes I combine the eyelid surgery with the orbital decompression, and this was a case like that. After the surgery, his eyelid position was fine, and his strabismus was corrected very recently. But we still have to tell the patients they may need revisions if we do a one-step surgery, because of the congestion, it may be difficult to align the lid height and the globe position. So as a take-home message, except true emergencies, we have to operate after the disease inactivity. The journey, the surgery itself is a long journey, so we have to be patient, and also the patient has to be patient. Decompression is the first stage, strabismus second, and eyelid surgery is the final refinement. One-stage surgery is possible in selected cases, but we have to warn the patient about the possibility of revisions. Thank you.
Thank you so much for the very well elaborated and excellent insight into the oculoplastics. Now our next speaker is also a chairman of this hall, Zafar al-Islam. He will be presenting on a rare congenital disorder, the cryptophthalmos.
Again, good morning, dear all. It was really nice presentation, the previous one, and the message was very clear. Whenever you do first decompression, then squint, and then in the end lid, just to repeat it. So now my presentation is a simple difficult disorder, that is cryptophthalmos, not really very easy to tackle. It's actually cryptophthalmos is failure of separation of eyelid from the globe during gestation, and the term was first introduced by Zander and Mans in 1872. There are three varieties: complete, incomplete, and abortive type. In the complete variety, the skin passes continuously from the forehead to the cheek. Globe is rudimentary and the eyebrow is almost absent. You can see only vertical column of hair at the side of forehead. Then in the incomplete variety, it's a rudimentary lid is present, globe is rudimentary. So in both cases, it's very difficult to do any useful operation. The only condition where you can do something is the abortive type, where there is a normal lower eyelid, varying amount of lateral part of the upper lid is present, skin of forehead attached to the superior retina, and it may cover whole of the superior retina, or maybe just top of the cornea. Skin of forehead attached to the superior cornea, or maybe whole of the cornea, like in this case, or maybe half of the cornea. It's the luck of the patient how he has been born, and absent or deficient eyebrow. I have operated on 10 eyes of 8 patients over about 12 years of period, and a number of surgeries were performed. On average, I perform about 2.2 surgeries. In some cases, I have to perform about 5 surgeries. There have been problems. End-to-end anastomosis in 2 patients, tensor flap in 7, McGregor flap in 1, mustarded lid switch flap in 5, and pharynx reconstruction with mucosa in 2 patients. This is one of my case. Its loss is about 60% loss. So I decided to go for the lid switch flap, mustarded lid switch flap. Here you can see I have taken a flap. I have quadrangulated the defect And now I have taken flap from the lower lid, which is 4 millimeter width, rotated it, and then after 6 weeks I opened it, and this is the result. And you can see here, you can compare the cornea, is more shiny, and you can see the lid. Tarsal plate is there, lid is very stable. The eyelashes, although eyelashes are not compared to this one, later on one can do some transplantation of these eyelashes to more middle part. But overall anterior segment is bit defective, but this patient had some useful vision. So I found this procedure very well. This is another case where bilateral crypt ophthalmos treated with tensor flap elsewhere. I presented with infection. I treated first the infection and then went ahead with lid switch flap. And this was the result after opening, and you can see the nice upper and lower lid contour, etc. And this is a small video. You can see I told you you have to fashion the upper lid, you rectangulate it, and then later on you take about vertical incision in the lower lid about 4 millimeter, and then horizontal cut according to how much you need, rotate into the upper lid, stitch in multiple layers, at least 3 layers. You stitch it till end, and then you go ahead with after 6 weeks you open it in such a manner that you first correct the upper lid. You have to do a pentagoning, some of the pentagoning, so that you should get good upper lid contour. Now a tensor flap for the lower lid, and any excess tissue you have to excise here, and this was the result of that surgery. So I've also always found the lid switch flap better than the traditional Cutler beard flap, what we have been doing mostly. This is another case where there was a bilateral cryptother 4 years old. The defect was about 1/3, and I did tensor flap, and this was the result where you can see a nice upper lid. Luckily, he had a normal cornea on the right side, and the left there was a bit of haze, but the results were really good. In one of the patients, it was very different. After every surgery, you have to wait for about at least 6 months for resurgery. So in the meantime, I went ahead and I actually used this lateral part of vertical column of hairs to form the eyebrow actually, and here you can see and compare this. There is an absent eyebrow, and this was an improved. This patient didn't come later. I mean, I want to do something for the upper lid, but he never come to me again. But this is a nice result. So in fact, in conclusion, I would say only about a type of cryptophthalmos is amenable to some kind of a surgery. Upper lid defect may range from 1/3 to full length, less than 1/3. Be prepared for surprises during surgery. It may need 3, 4, even more operations that you have to keep in mind. Tensor is suitable for less than 1/3 in children. In adults, you can do up to 50 to 60% defect. You can do tensor flap, but not in children. If you do it, it will open up. Remember, if defect is more, then it won't work in young children. Its skin is very tight, and vision acuity depends on clear cornea available and anterior segment defects really on that. Thank you very much.
What we should offer to parents for complete cryptophthalmos?
Yeah.
Susan sir, we are already having short of time. Can we have this question answer session at the end?
I can't really. I mean, it's a rudimentary globe. Always remember it. Globe is not there. बाद में ख्याल होता है कि हम खोल लेंगे, we will get some globe. You can do ultrasound and show them normal ultrasound. Then what the difference is. So that's, you have to convince them, and it takes time. Okay.
We have been treating this disease with various ways for the last many years, I think 3 decades. We have been doing myectomy. We have been doing differential section of facial nerve for a long time, and there was a lot of recurrence. Then we have been doing sling with different materials and different types. But for the last 5 years, I have been doing this surgery. I will show you, and I decided to present at this forum because I got very good results. Now, blepharospasm, benign essential blepharospasm. Benign means it has no malignancy, it is not life-threatening by itself. And essential means there is no known cause not known to us. Now, diagnosis is we see the movement of the lids, and we observe, we ask the history for how long, what is life standing, and lastly we don't need any laboratory test for this to diagnose this disease. And we have to exclude the other causes, which are the secondary causes, which are dry eye, blepharitis, eye irritation. Then we have to, there can be Meek syndrome if there is oral involvement, and we have to rule out the extrapyramidal and dysfunction of the basal ganglia. Similarly, the patients may have the light sensitivity. Now, this study was done on 11 patients in the last 5 years at my clinic. I have been retired for the last more than 5 years, and there was 6 female and 5 male patients. Age was between 39 to 70 years, and this disease is disease of old age. Now, these are the breakup of the patients, male and female. About the first line of treatment, we know that it is a Botox injection, and out of my 11 patients, 4 have been getting this treatment. One patient was very regular in taking the Botox, but rest of the patients, they have been given injection for different time. Now let me talk about surgical technique I do, because at this stage we should decide these things rather than reviewing the literature. Now, incision I made is blepharitis, superior blepharoplasty incision. Oh, light hai? Because at this age there is a lot of redundant skin, and we remove this skin with this incision, like this. Superior blepharoplasty incisions. The one line is on the crease, and the upper line depending upon the extra skin we have. Then the next step is we make 3 stab incisions. 3 stab incisions above the eyebrow, and similarly these are the marks where we penetrate the tarsal plate. And the type of sling I used was the double rhomboid technique. I like it because we get excellent contour with this technique. The material used was 5-0 Ethibond. The double rhomboid is one thread is passed like this, go like this, go, and this one. Similarly, the second thread like this and this one. In this way, we pass two Ethibond 5-0 in double rhomboid fashion. Then we close the lids in double layers. Now, immediately after surgery, the next day, the picture will be like this. Small incisions on the eyebrow, 3 stabs, and then on the lid. And the suture were removed after 10 to 12 days. Now, once I do this sling surgery, and at the same time I inject absolute alcohol at the lateral border of the orbit at 3 places, because we know that the nerves are underneath the muscle. I inject a 0.5 ml here at this level, 0.5 ml at this level, 0.5 ml at this level. And it means that on the one side I inject 1.5 ml of absolute alcohol. At the lateral border of the orbit, we hit the bone and there inject 0.5 ml of absolute alcohol. Similarly, below down and then the below down. This injection was given at the time of surgery, and then this injection was repeated every month 4 to 6 times. This injection, because there was a recurrence, and this was repeated 4 to 6 times. With this treatment, we have excellent results. Now, you will be surprised, I have very few complications. The reason is because I myself is doing, the surgeon is, all the run is by myself. And you know, in complications come when there is exposure of this filament suture. This is a braided suture, and if there is film exposure, there is a lot of complication. And ultimately we have to remove this suture to avoid this complication. So the chances of exposure is when we are taking making the incisions of the tarsal plate, it can come down, we should check it. And the second chance of infection is at the stabs. On the sides there is a knots, we have to bury it, and we have to cover it in double layer carefully. These are the places where we get infection. If you are very careful, we have minimal infection. We had only 2 complications in these 11 cases. In one there was bone infection. In the other case, when I completed the surgery, the thread was passing above the skin. I have the patient. So make the incision and buried it. Ever since, patient is alright. It's more than 1 year past. So the complication chance in this, the complication is very few, and they were manageable. Now this is the patient. Let me show the pre-operative. जी है, ये है मेरे पास है जी. निशाना लगाना थोड़ा मुश्किल हो रहा है मुझे. ये अगले चला गया, इसे पीछे वाला करें, इसे पीछे वाला करें, और पीछे इसको चलाएं, डबल लेट, इसको नहीं फिर आगे चला गया. मुझसे उसे भी लगा, इतना डिफरेंस नहीं मिला. इसको हाँ जी, डबल क्लिक करें इसको, नहीं ये छोटे पे चल जाएगी, मैं चलाता हूँ. हाँ एस्केप करके चलती है. यूर राइट, ट्रू यूर राइट, मैं करता हूँ. नहीं आएगी, चलेगी. मैं करता हूँ, छोड़ दे. नहीं मैक्सिमम नहीं होगा, फिर चलेगा नहीं. दोनों साउथ पंजाब के हैं. मैं खुद भी साउथ पंजाब में आजकल अभी मैं दरमियान में हूँ, 600 किलोमीटर पे. Now this is pre-operative, and इसको बैक करें प्लीज. अच्छा, और दिस इज द पोस्ट ऑपरेटिव वन. Patient is comfortable. I think it's more than a year to he has been operated. Now next one. इससे पहले ये. Now this is a patient. This is the patient where I got when I completed the surgery, I saw the thread outside the skin. There I made the incision and then buried it. I was worried it will be bad outcome, but everything settled. Now इसको मैं दोबारा करता हूँ. ये भी इसका प्री ऑपरेटिव है जी. ये प्री ऑपरेटिव आदमी का. इसका मैं फीडबैक भी दूंगा बाद में आप में. चलो नेक्स्ट वन, इसको पीछे करें प्लीज. ठीक है. अच्छा लें जी अब. सॉरी नहीं, इसे अगला करिए. ये इसको तो मैं करूँ. ये फीडबैक है जी इसका. डबल क्लिक करें, आप करें और ठीक है। आवाज करें, अभी 2 मिनट हैं जी, अभी चला जाऊंगा। इसकी आवाज करें ना, इसको मैं से पूछ रहा हूँ कि ऑपरेशन कब हुआ, बता रहा है ये। नहीं वो गल भी सुन लो ना की कहता है, नहीं दसेगा भी नाल।
Sir, mashallah, excellent work, but we have short of time. Yes.
मेरी वेरी शॉर्ट टाइम। चलें जी, ये फीडबैक हुआ, अब इसको नेक्स्ट वन करें। इसमें से क्वेश्चन पूछ रहा हूँ, सर्जरी कब हुई थी, मोर देन 1 ईयर। बाकी फेस की हिस्ट्री है, बोटॉक्स की रेगुलर इंजेक्शन वो बता रही है, वो उसमें आई नहीं आवाज। नेक्स्ट वन, वीडियो नहीं वीडियो खत्म, अब नहीं वीडियो आएगी। इससे नेक्स्ट स्लाइड करें ना, इसको ऑफ करें, एस्केप करें, ये ले जो छोड़े। इससे करो, अब उसको चेक मेजर भी कर ले। अच्छा, इन समरी this is a good technique. These are the results which I already mentioned in my description. Next one. Next slide please. हाँ, उन्होंने इससे पहले एक और थी, कंक्लूजन की है। Well, blepharospasm, benign essential blepharospasm, they have been operated with sling surgery in double rhomboid fashion with Ethibond 50 along with absolute alcohol treatment of the facial nerve periodically every month between 4 to 6 times, and this had very good result, only few manageable complication. The complication I told you, when there is exposure to the thread, then there are complication. Next, this technique is very easy to master, done under local anesthesia, least invasive, and of course in long term, not give long term relief to the patient to this disabling disease, and definitely cost effective for our public. Thank you, sir.
Thank you so much, sir, for the excellent presentation. Our next speaker is Dr. Muhammad Ahmed.
Me, unfortunately for you, a resident from the same department is presenting today in her place. My name is Dr. Mohammed Masnoon Ahmed. I'm delighted to have our Clinical Associate Professor Dr. Rashid Beg here today. He has, mashallah, completed 20 years with the Aga Khan University Hospital this year. So that's something to be proud of. I'm proud of it. Beyond steroids, novel thyroid eye disease interventions, I have no financial disclosure, neither does Dr. Zubaida Sirang. So when it comes to a thyroid eye disease and we are gauging as to how to approach a particular pathology in such a situation, we consider two important things, which is the activity of the disease and the severity of the disease. Activity, which means if there's an active inflammation; severity is there's functional impairment, and you can have the diplopia and other due to scarcity of time, functional impairments that are occurring. Assessments can be done on various classifications. The ones that we are most likely to be questioned on during our FCPS exams is the European group of Graves on Graves orbitopathy, the UGOGO, or I would be referring it as the European classification. The University of California, San Diego has their own visa classification. I will not be going into details of that. But one of the most important things is the clinical activity score. That is something that is key when you're assessing or inspecting or examining a patient of thyroid eye disease. In the initial visit, you grade the patient for 7 points. The 7 points are listed in front of you with spontaneous orbital pain, gaze-evoked orbital pain, eyelid swelling, eyelid erythema, conjunctival redness, chemosis, and etc. If the active diseases, when you have 3 of these signs present in the first visit, in the follow-up you assess out of 10 rather than the 7, including proptosis, decrease in ocular excursion, and decrease in visual acuity. If it is more than 4, there onwards, we are still in the active state. This is the European guidelines. This is the one that we are most likely familiar with, which divides it into mild, moderate, and severe. Severe has the DON and corneal breakdown. In moderate, there is lid retraction more than 2 millimeters, exophthalmos more than 3 millimeters, quality of life hampered. In mild, whereas the quality of life is somewhat sustained with mild lid retraction, mild exophthalmos. No or intermittent diplopia, whereas in the moderate you have diplopia. So management, how do we approach and how do we manage? The two important things that Dr. Zubaida wanted me to mention here today is the activity and severity has to be assessed according to whatever classification that you may choose. It is a multidisciplinary approach. It begins with us as ophthalmologists. We include the endocrinologists and radiotherapists and radiology to make sure there's adequate imaging that is done. And we have a wholesome approach towards managing a patient of such a condition. Treatment for mild graves, the control of risk factors, this is something we are aware of. Radioiodide uptake therapy, good control of hyperthyroidism, lubricating eye drops, and selenium for mild. Whereas when you go beyond and head into the territory of moderate to severe, this is an organogram that I was able to get from Dr. Zubaida's material that she gave me to prepare for this presentation. On the left are general recommendations. They're evident. I will not be going into details of that. But if we begin, either we can approach it as a monotherapy or as a combination therapy. There are randomized clinical trials conducted in the West that do favor the decision to proceed with the combination therapy rather than monotherapy. However, the most rampant that we see is the monotherapy in our setting. Combination therapy is with IV methylpred, 0.5 grams and mycophenolate sodium, and if you assess for the response, if there's a response, if so, you decrease and taper the IV methylpred, continue mycophenolate, and you get this response, and eventually you stop therapy when the patient is beyond the active state. If there's no response, we move to the second line therapy, and the second line treatment is why I'm here today. Monotherapy is the same. The dosage is a bit more. Instead, we proceed with 750 milligrams rather than 500. Glucocorticoids and immunosuppressants, you can combine them in the treatment. Again, there have been randomized clinical trials, but there is a bit of a division when it comes to the effect and the therapeutic overall effect of a combination therapy. But it, due to a randomized clinical trial conducted in 2022, did say that combining the ones that I've mentioned in these doses that I've mentioned, they overall do benefit the patient. However, there has to be quite a selection. For patients you're about to give immunosuppressants for, so basic baseline investigations have to be completed. So, teprotumumab. Now, this is end of this year. We will be having Dr. Hassan Shah, who is an AQ alumni, currently in the University of Illinois Chicago. He will be visiting us, and and he's a visiting faculty as well. He visits us quite often for unique cases that we discuss and get in amazing time with him in one-on-one sessions. He told me that this is the go-to medication for how they're managing thyroid eye disease in the US and in his setting. Sometimes the second line also trumps the decision to go with the first, which is teprotumumab. It's a human monoclonal antibody against the insulin-like growth factor 1 receptor, considered as a breakthrough in the treatment of Graves. First targeted disease-modifying therapy, first approved from the FDA in 2020. The evidence is the RCT is done, large multi-centers which do present as a proponent evidence of the use of this medication. It reduces proptosis by more than 2 millimeters in 83% of the patients, improves the clinical score, diplopia, and quality of life. Limitations, however, cost and limited global availability, the story of our life, potential side effects, contraindications, irritable bowel disease, and pregnancy. The dosage administration is 8 IV infusions over 24 weeks. The first dose is 10 milligram per kg, and subsequent doses, 7 in total, are increased from 10 to 20 milligrams per kg for every 3 weeks. Rituximab, this is something that is not unfamiliar to us. We are very well aware of the effects. Monoclonal antibody targeting CD20 on B lymphocytes, B cell depletion antibody, complement-mediated mechanisms, improvement in the score, proptosis, extraocular motility has been documented. However, randomized clinical trials have had conflicting results, and assessing from what my conversations and our lectures with one of our faculties were, as I mentioned, Dr. Hassan Shah, there seems to be less inclination towards rituximab as a treatment for moderate to severe Graves' orbitopathy. Side effects are listed. Tocilizumab, IL-6 receptor antagonist, promotes orbital fibroblast and adipocyte activation. Case series IL-6, so this is an antagonist for that. Case series small scale studies have shown the benefit. Something that the literature is still is yet to convince for massive guideline changes, but it's there on the horizon. It is something that will be considered as strictly as teprotumumab. They're very hopeful for it. Orbital radiotherapy. The second line treatments that are new due to paucity of time, I'll be heading towards that, are batoclimab and small molecule TSHR inhibitors. Batoclimab is a humanized monoclonal antibody targeting the neonatal FC receptor and leads to reduced recycling of IgG, including pathogenic autoantibodies in the TSH receptor mediated antibodies. By decreasing IgG levels, reduces inflammation and tissue remodeling in orbital tissues. The phase 2 clinical trial was terminated prematurely due to dyslipidemia. Weekly subcutaneous injections of 680 milligrams for 2 weeks, followed by 340 milligrams for 4 weeks. There has been improvement documented. However, still over the horizon. Small molecule TSHR inhibitors selectively block the thyrotropin receptor, a key player in the pathogenesis of TED, suppression of fibroblasts, glycosaminoglycans, orbital tissue expansion, far away from that horizon, but there are animal and in vitro studies being conducted. Sight-threatening part, we are still resorting when it comes to DON and corneal breakdown for surgical decompression and the use of methylprednisolone. There's been heavily dependent on it. There has not been a other than teprotumumab being attempted, the ones that I discussed with you today have not been attempted for the treatment of the most worst possible position of TED. Thank you so much for your time. I hope you have a wonderful day.
I'm Dr. Satya Imtiaz, SR from Mayo Hospital, Lahore. My topic of discussion is atypical manifestations of mucormycosis. As the time is short, I will just rapidly go through it. What's the agenda of this my presentation is because mucormycosis has a high disease burden and is very severe because it can lead to a mortality rate. It can have atypical manifestations which require early diagnosis and timely management. So what is a little bit about its introduction is mucormycosis, or which is also known as zygomycosis. It's a fulminant angio-invasive fungal infection. Its incidence has increased much after COVID, high mortality without early diagnosis, and atypical cases requires high suspicion. If we go about its pathophysiology, we know that is following the route of entry are two. One is the inhalation and the other is the skin trauma. Through the inhalation, the spores enter into the nasopharynx, and from there these enter into the sinuses, orbit, and then into the cavernous sinus. Okay, so if we go for about this one, we know that the neutropenia is a risk factor for the fungus proliferation, as well as if there is free iron level, iron overload, that can also lead to the fungal proliferation and high rapid growth. So once it is in the blood, it causes the thrombus formation, which leads to the ischemia and necrosis and rapid tissue destruction. One is the inhalation and the other is skin occlusion due to some trauma or because of the surgery as well. So what are the risk factors? The most common risk factor is diabetes mellitus, which can be present in 70% of the individuals. Second is patient can be on the steroid therapy, which can be present in 50% of the patients. Other less common being the hematological malignancies like the leukemia, neutropenia, immunodeficiency syndromes, and not to forget post-surgical or the trauma cases in 10% of the cases. I was wondering why mucormycosis and other fungal infections are becoming so common among our population in Pakistan. This can be because of, other than these risk factors, because of less sun exposure, living in the overcrowded spaces and industrial as well as the agricultural country, these are becoming very much common nowadays. So what are its typical features? We know that mucormycosis normally present in the immunodeficient, immunocompromised individual, and the most common presentation being the rhino-orbital cerebral disease, where the fungus has invaded the sinus or the nasal cavity, and from there enters into the orbit, causing the proptosis, ophthalmoplegia, optic nerve compression, and from there entering into the brain, causing the cavernous sinus thrombosis or the stroke. So the topic is actually is atypical manifestations of mucormycosis. So what are atypical manifestations? For this, I will rapidly go through this case. This was 2-month-old infant which came to us after 2-week history of left orbital swelling. He was already on IV antibiotics and was not responding to this one. Initial imaging was done and it showed that the lesion was only involving the medial side of the orbit. So, because the patient was already on the first line IV antibiotics, so we decided to go for the biopsy. We showed only the necrotic inflammation at the first time. Second line IV antibiotics started in consultation with the pediatric medicine. IV meropenem and the Venco started, but the patient didn't respond to them and the disease progressed. And it involved the whole side of that face as well as extending upward to involve the forehead as well. Okay, so we decided to go for another neuroimaging. We showed that the lesion or the tumor or whatever it is involving the ipsilateral side of the whole of the face, and there we found many abscess-like cavities, as well as the plane was only in the subcutaneous plane, that it was not involving the deeper down into the bone, and it was not also involving the cavities, nasal cavity or the sinuses. So we planned for the rebiopsy along with in consultation with the maxillofacial department, but this time we actually went for 2 specimens. One specimen was sent in the normal saline for the fungal culture and AFD, because we have a suspicion for the tuberculosis as well, and another specimen was sent in the formalin for histopathology, and the pulse was also sent for the culture sensitivity, and this was the picture at that time. So coming towards the diagnosis, first report we received that of the pulse, and here you can see that the moderate growth of the mucous species was found within 48 hours, and the second report came that was of fungal culture, and it was after 72 hours, and it also showed the mucormycosis. In the third one, which came after 5 days, and it was of histopathology report, and it also further augmented our diagnosis. Next workup was done, why this patient has actually the mucormycosis, because he was only 2 months old and there was no precipitating factor. So initial workup showed only the anemia, viral markers were negative, and further when immunophenotyping was advised, and it showed that all the CD4, CD8 count all were decreased on the lower side. So in consultation with the pediatric medicine, infectious pediatric medicine department, we actually started the patient on IV antifungal, amphotericin B, and these were actually the pictures as the patient was going through all these stages, and it was very hard for us to see the child suffering from all this. And the patient attendant were not they were counseled, but they were not agreeing about the debridement until this scalp started removing itself. So here we went for the debridement. Extensive debridement was done, but at this stage the attendants were not willing for the exenteration, but in the second stage they were counseled about that properly and the exenteration was planned. This is actually 4 weeks following the IV amphotericin B and the debridement. Serial debridements were done, and this child is actually doing very well after 6 months of the therapy. Our future plan is to go for the amphotericin B, which was continued till 6 to 8 weeks, and next plan you can shift the patient on to oral posaconazole or isavuconazole, which one is available to you, 3-month neuroimaging and the plastic surgeon involvement. Other atypical cases, we actually went through these ones. One case was having the post-decompression. We did the decompression surgery, and afterwards the young patient developed the mucormycosis, and here we started amphotericin and he responded very well. Another was the child with orbital cellulitis. Biopsy initially was done because we were very much concerned about that, and both had no sinus involvement, that the typical of the rhino orbital mucormycosis was not seen. This was the second case where initial diagnosis was orbital cellulitis.
I think Sadia, only one case is enough.
Okay, it's done. It's done. Okay. So this was 1 week following the amphotericin B. So the key take is suspect the mucor in non-resolving orbital infection. Sinus clear does not rule out the mucormycosis. Always send the specimen in the saline as well as the formalin. And early liposomal amphotericin B has a better prognosis. So in conclusion, atypical mucor mimics the routine infection, high suspicion, early diagnosis, and better survival. And combined surgical as well as the medical treatment is the recommended one. Thank you so much.
Thank you so much, Dr. Sadia.
Appreciate your speed.
Yes.
We have only 3 minutes left.
Right, sir. Respected seniors and
Yes,
my
we
colleagues,
have one more
Assalamualaikum.
speaker.
So, I'll just be talking about this new differential that comes up now, and for orbital swelling, and that is IgG4, and our experience at our institute over the last 5 years. So it's a newly recognized, we know that the theory of it, that IgG4 is a newly recognized immune-mediated multi-organ, multi-system disease. And this term was recently coined in 2011. Before that, it was labeled with different names involving different parts of the body. So here's a retrospective case series that was published from our side. And we had 66% of our patients were male and 33 were female. The youngest was 24, the oldest 69. The major manifestation in our setup was axial proptosis, second was mass, and then dystopia. 2 of the 9 patients in this published data had bilateral disease. 2 of the 9 patients had systemic manifestations at the time of presentation. One was diagnosed case of diabetes insipidus, and the other had xanthogranuloma. Age of the 9, how the interesting thing was, 8 of the 9 of our patients had normal levels of IgG4, which according to the diagnostic criteria, we need to have either 3 of these, presence of a clinically symptomatic swelling, hematologically 135 crossing IgG4 levels, and pathology confirmatory report. So majority of our patients had 1 and 3 as present, so they were probable IgG4s, not definitive. So the involvement that we saw was the ones highlighted in yellow. So we saw lacrimal gland involvement in quite a few, soft tissue involvement, NLD blockade, extraocular muscle involvement, scleritis and xanthogranulomata. However, we did not see nerve enlargement or destructive bony lesions, which literature suggests. In many of the initial publications of IgG4 disease, infraorbital nerve enlargement was considered almost a pathognomonic feature of IgG4. None of the patients that we saw had it on imaging, and it is significantly correlated in patients who have raised levels of serum IgG4. Sensory loss because of the involvement of the nerve is extremely rare, so the nerve might be enlarged, but there is no numbness and paresthesia at that area. 2 of these 9 patients needed a repeat surgery for regrowth. 1 of them ended up with exenteration. So the eventual visual acuity in 5 of the 9 patients was 6.6, and 2 of the 9 had counting fingers. The PL negative was in patients who had the regrowth, and we had to do a redo surgery. So we were fortunate enough, we could talk to 6 of our patients. We called them up, and we've kept them on a follow-up. 1 of our patients is on a long-term liaison with the rheumatologist and is on immunosuppressants. The interesting thing was that the patients who had unilateral involvement and lacrimal gland involvement, they're still doing well. So we specifically questioned them about GI symptoms as well, pancreatitis, cholangitis, jaundice. None of them has had anything. So that's a good thing. So just a brief, it's a newly cropping up disease. Majority of the cases have been reported in Japan, from where the term initially came. Majority of the involved patients are males, and males end up having more extraorbital involvements as well. It is associated with other pathologies as well. It's an immune-mediated process, so asthma, allergic rhinitis. We saw a patient of xanthogranuloma, and 1 of our patients eventually developed multiple myeloma. So the conclusion is it's a very scanty information. It's only a case series of 9 cases. This was published way back, about a year back. So far, we've enrolled 17 patients of IgG4 in our setup.
Finish in 1 minute.
So we need a longer series, and we need a good liaison with an internist to find out what is the spectrum of the pathology in our part of the world. So I just came across this, that the zebra is the mascot for rare diseases. So the zebra striped ribbon is for patients suffering from rare diseases, including IgG4. There's a saying that goes, when you hear hoofbeats, think horses, not zebras. As in, when you come across somebody with a pathology, think of normal things first. But we have to keep our eyes open for rarer pathologies as well, because this is something which is potentially life-threatening as well, and vision-threatening. Thank you so much.
Thank you so much. Our next speaker is Dr. Adnan Abdul Majid. Please run towards the podium.
Gentlemen, today my topic is rare orbital masses mimicking the neoplastic lesion. Myself, Dr. Adnan Abdul Majid, consultant ophthalmologist at SIUS Hyderabad. So the background is orbital space occupying lesion often mimic the neoplastic disease clinically or radiologically, and etiology may differ from neoplastic, infectious or inflammatory. A definitive diagnosis obviously need a histopathological confirmation. Today, I would like to present a case series of 4 orbital masses which was mimicking as a neoplastic lesion, but later on found to be having a different etiology. So, discussing my case number 1, a 30-year-old male with a history of progressive painless proptosis of the left eye for last 6 months, which was associated with a decreased vision and diplopia. Clinical examination was axial proptosis of 24 millimeter in the left eye versus 16 millimeter in the right eye. There was a hypertropia associated with the dystopia. So this was the picture of presentation of this patient. When we went for the investigation on MRI, we found that there was a left orbital intracorneal mass. Some size was 3.2 to 3.1 into 3.8 centimeter. And MRI T1, it was a hyperintense, and T2 with the fat saturation, it was hyperintense with no contrast enhancement was seen. There was a mass defect with the displacement of extraocular muscles and compression and shifting of the optic nerve. As you can see, the white circle area was the mass. So on histopathological finding, it was found to be a orbital hydrated cyst, which is very extremely rare. So this was the post-operative image of this patient. Later on, after the operation, we put this patient on medication, anti-parasitic therapy, and albendazole is one of the drug of choice for this type of etiologies. So orbital hydatitis is extremely rare, representing only almost 1% of all the hydrated diseases cases, and less than 1% of orbital space occupied lesions, even in endemic regions. So this is my case number 2, 37-year-old female with a history of progressive painless proptosis of the right eye for last 6 months. There is a peri-orbital swelling, more marked on the medial side. It can be seen in this picture. And clinical examination, there was a right eye proptosis with peri-orbital swelling, especially on the medial aspect. So when we went for the investigation on MRI, we found there is a medial extracorneal lesion measuring 3.1 into 1.4 into 2.8 centimeter. On T1, it was a hyperintense with hyperintense on T2. Homogeneous enhancement was found, and there was a compression of the medial rectus and globe, causing a mild proptosis and impression like a cavernous hemangioma. But we went for the histopathology. It was found that it is basically a spindle cell hemangioma, which is extremely rare in the orbit. So this was a picture of a patient post-operatively. So a spindle cell hemangioma is a very rare benign vascular lesion, most oftenly found in the distal extremities, but its occurrence in the head and neck is extremely rare. Only 11 cases have been reported in the English literature till yet, and orbital involvement is also very rare in this case. So this was my third case, a 22-year-old male with a history of residual painless progressive proptosis for last 4 years. On clinical examination, there was a right eye proptosis of 24 millimeter. There was a non-axial outward dystopia, orbital fullness with a brow elevation, dystopia of 10 millimeter horizontally and 3 millimeter vertically, and orbital margin were intact, there was no tenderness. On MRI, we can appreciate this lesion. So it was a large lesion, extracorneal as well as intracorneal, which was infiltrating the medial rectus and superior oblique bellies, and which was causing the proptosis and lateral displacement of the optic nerve, which was hypo-intense in all sequences, and homogeneous enhancement was seen. It was locally aggressive orbital neoplasm, which we went for the histopathology, and we found that it was a orbital fungal granuloma. So this is the post-operative image, and we started after the operation antifungal for this patient, and we monitored LFT as well for this case. This is my last case of 25-year-old male with a history of bilateral upper lid swellings in last 5 years, which were gradual, painless and progressive. No visual complaint or systemic sign symptom was found. And clinical examination, there was a bilateral diffuse non-tender superior orbital mass with a severe mechanical ptosis, no proptosis, and extraocular motility was full. Vision was normal, and anterior posterior segment was also normal. On MRI, we found there is a bilateral symmetrical diffuse enhancement of the lacrimal gland, extension of anterior medial into the preseptal area and lateral rectus displacement, and the impression was bilateral lacrimal gland enlargement, likely sequela of the sarcoidosis. So when we excised this was the mass which we excised, and later on when we given the histopathology, we found that it was a benign reactive lymph nodes. So this was the post-operative image. We went for the first eye surgery, then this is the second eye surgery. The last time we went. So this is the second eye post-operative image. So benign reactive lymphoid hyperplasia is a rare orbital disease, accounting only for the 15 to 20% of the orbital lymphoid lesions, and orbital lymphoid lesions overall comprise of 8 to 11% of all orbital tumors. So my take-home message is, in making the orbital disease diagnosis, we have to presume clinically, consider radiologically, but we have to believe histopathologically. Thank you. And the last, I would like to thank my supervisor, orbital population Dr. Faya, because these were the cases of her, and we managed these cases collectively. Thank you.
Thank you so much, Dr. Adnan. Now I would like to invite Dr. Salman Hamza.
4 sessions, rather instruction courses are supposed to be happen in the Shalimar C at 2 to 3 p.m. It's for the endonasal DCR surgery, and it's hands-on. You are all requested to join there. And then after that, aesthetic from 3 to 4 p.m. And the last one, the big show for Imran Akram Sahab. He is talking about the integrated approach of the squint. It's from the 4 to 5 p.m. So you all are requested to come and join there. And I will invite Dr. Sophia, Professor Sophia Iqbal. वो उनको शील्ड देनी है.
छोड़ो. हाँ जी जी.
Why? I mean, there has to be some incompetency, which was not discussed.
Yeah, I mean, she said that we did all kind of studies and we don't know how and why it happened.
It has to be there.
It has to be there. Yes, कुछ ना कुछ होगा जो ये हुआ है. Yes.
हो सकती है.
Yes, and I'm just surprised that the patient is surviving. I mean, the way it was progressing, it's very commendable job she did.
Thank you.
Any other, and all the attendees who have attended it, and they will see you at 2 p.m. after our lunch again.